Hello and welcome to Chapter 3 in Alternate Care Systems in our Comparative Health Information Management text. Chapter 3 is going to cover freestanding ambulatory care. We're going to start in Chapter 3 on page 70 if you want to follow along in your book. I'm going to skip past these learning objectives in the PowerPoint. We're going to start with our care settings. So introduction to setting. Freestanding ambulatory care differs from hospital-based ambulatory care in that freestanding ambulatory care sites are not owned by or operationally integrated with the hospital. The various freestanding settings include public health departments, community health centers, rural health clinics, and urgent care centers. The settings in which most people receive care is the physician's private practice. The type of ambulatory care facility determines the type of patient seen, the type of caregivers, and therefore the types of information collected. So, a large portion of the freestanding ambulatory care is provided by physician private practices, and this is the office where physicians see outpatients or ambulatory patients. Physicians can practice alone, which is a solo practice, or they can practice in groups. Groups usually involve 3 or more physicians, and they could be all of the same specialty or could be different specialties. Physicians practicing together usually share records, equipment, and offices and have an arrangement to divide the profits of the practice. Historically, these practices have been the most common setting in which ambulatory care is provided. Other types of ambulatory care have been developed to meet the needs of patients. The public health departments, for example, provide a variety of services to improve the health of the community as a whole, in addition to health care for individuals. Emphasis is placed on preventative services such as immunizations, screenings, and notifying contacts of patients with infectious conditions such as tuberculosis and syphilis to prevent further spread of this condition throughout the community. Community health center setting came into being as a result of a federal social legislation in the 1960s. The purpose is to meet the needs of people who, because of their location and their inability to pay, may not receive the care they need in a traditional physician's office or clinic. These clinics typically serve a defined neighborhood area that typically is an underserved area or population. And in 1989, there became federally qualified health centers. This was through Medicare and Medicaid, and they're nonprofit or public organizations that provide or arrange for comprehensive healthcare services to medically underserved areas or populations. They offer a sliding scale fee, and they provide comprehensive services and have ongoing quality assurance program, and they also have a governing board of directors. Our next setting is the rural health clinics. This is a healthcare clinic that utilizes advanced practice clinicians such as physician assistants and nurse practitioners in addition to physician services and is located in an underserved area. RHCs make health care services available to non-urbanized communities as defined by the U.S. Department of Commerce Census Bureau. RHCs offer services that might not be accessible if the services were reimbursed with traditional payment models. And then we all know about urgent care centers. These arose to meet the need for care outside of the regular physician's office hours. Prior to urgent care centers, patients sought care in expensive hospital emergency departments. Urgent care centers usually see patients on a walk-in basis without appointments and provide the same services as physician offices. Most urgent care centers are open 7 days a week, plus holidays, to meet the needs of the patients. And then you have your ASCs, your ambulatory surgery centers. These arose to meet the need for a less expensive setting than the hospital for low-risk surgical procedures. Its growth was fed by the Omnibus Reconciliation Act of 1980, which set up a Medicare payment system specifically for ambulatory surgery centers. Although some physicians perform minor surgical procedures in their offices, the main difference in a freestanding ASC is that it usually has at least one full dedicated operating room, is often licensed by the state, and provides surgical privileges to doctors in the community, not just in one practice. Then we have our industrial and occupational health centers. These provide care to employees at their place of work or at an employer-contracted site. Services range from providing care for work-related injuries to new employee evaluations and return-to-work physicals following an accident. All right, flipping over to page 72, we're going to follow up with university health centers. These provide care to students while they're enrolled in college and in some cases also to faculty and staff. Some centers provide only minor services where others provide a full scope of care. The extent of their services often depends on the size of the university and the range of services available to students outside of the university community. Then we have birth centers. This setting arose to counteract what was thought to be a rigidity by hospitals in providing birthing options. Birth centers provide a home-like atmosphere for deliveries and provide contraceptive and other family planning services. Hospitals historically would not allow family or other support persons within the labor and delivery suites. And alternative caregivers, such as midwives, also were not allowed to perform deliveries. Freestanding birth centers and family planning centers were developed to provide the home-like environment requested by patients, along with a variety of caregivers providing support. And so this brings us to the family planning centers. These were established by the U.S. Department of Health and Human Services Office of Population Affairs Title X funding. Family planning centers often offer various FDA-approved contraceptive methods and counseling, breast and cervical cancer screening, pregnancy testing and counseling, screening for sexually transmitted infections, and patient education. All right, so now we talked about our settings. Let's talk about our different types of patients for ambulatory care. The first factor to consider in developing health information management services is the type of facility, and then the second is the type of patient seen in the ambulatory facility. So, patients seen in your outpatient areas are typically not critically ill. Care may be provided to well patients as well, so there you have your wellness care. And so, wellness care is going to be an example of taking your baby to their well baby visits, and then health screenings. Having Healthy You visits for your insurance, just getting that routine blood work done yearly. Most of the patients, however, are the ambulatory sick who may have minor acute problems such as sore throats and earaches, or chronic conditions such as heart disease and diabetes. All ages of patients are included, and some facilities only see a certain type of patient. For example, your birthing centers, they're only going to see pregnant women. And then, of course, you have clinics specialized for, children. You have clinics for urology patients. You have clinics for your cardiology patients. So you have different specialty clinics. Now, let's talk about caregivers. A lot of the same caregivers that you see in the hospital setting, physicians, nurse practitioners, midwives, nurse midwives, not necessarily seeing those in the hospital. See your physician assistants, there's dentists, nutritionists, counselors, therapists, psychologists, social workers, chiropractors, one you don't necessarily see in the hospital, and then podiatrists. All right, so we're going to skip over to our regulatory issues now. But again, remember, these lectures are just the highlights, so you're definitely responsible for reading the entire chapter to get all of the content. Just hitting the key notes here. All right, so regulatory issues. Determining the type of caregivers in a facility identifies both who is entering information into the health information system and the internal users of the information. The regulations that a facility must follow determine the external users of information and standards for what information should be maintained. Regulations and standards usually are determined by licensure, accreditation, and certification bodies. So, licensure. Laws vary from state to state. Licensure does not usually apply to physician offices, and licensure does usually apply to your ambulatory surgery centers and your birthing centers. Ambulatory surgery centers and the birth centers, who have to meet the licensure standards, they have rules for what information the facility must maintain in its health records. They are therefore an excellent source of information on what must be included in the information system. The content of the medical record for an ambulatory surgery center is similar to the content of the hospital record. And if you remember, we learned that in health records in the first semester. All right, changing over to page 72. Medicare certification talked about conditions of participation. Certain types of healthcare facilities must be Medicare certified according to the Medicare conditions of participation or conditions of coverage before they can participate in the Medicare program. Conditions of participation or coverage exist for ambulatory surgical services, for rural health clinics, and for federally qualified health centers. In the case of rural health clinics, Medicare certification confers a special status that permits reimbursement from both Medicare and Medicaid. Medicare standards for rural health clinics and FQHCs include a requirement that records be maintained for each patient and that a designated professional staff member be assigned the responsibility for maintenance of those records. All right, dropping down on page 77 to accreditation. And we've talked about the differences between licensure and accreditation. Licensure is required, and then accreditation is so-called voluntary. But unlike licensure, which must be undertaken if required by the state, accreditation is a voluntary process. There are a variety of organizations that accredit ambulatory care facilities. Some are the Accreditation Association for Ambulatory Healthcare, Inc., and the Joint Commission. They both accredit a wide variety of ambulatory settings. And then you have other accrediting organizations like the American Association for Accreditation of Ambulatory Surgery Facilities, Inc., that only focuses on a narrow segment of ambulatory care. Moving over to page 78, the very bottom, the Office of Inspector General, or the OIG, in the Department of Health and Human Services is charged with protecting the integrity of Health and Human Services programs such as Medicare by detecting and preventing fraud, waste, and abuse. This office has identified large sums of money that providers receive through error or fraud. The Department of Justice has recouped billions of dollars under laws such as the Federal False Claims Act and the Health Insurance Portability and Accountability Act. Every year, the OIG publishes a work plan outlining the focus areas for the upcoming year. To ensure compliance with billing and reimbursement rules and to avoid the potential for penalties, providers are encouraged to develop a compliance plan that ensures conformity with federal requirements. The OIG has published model compliance plans to provide guidance for a variety of health settings, including individual and small group physician practices and developing internal controls. These plans include the following 7 components: conducting internal monitoring and auditing, implementing and compliance practice standards, designating a compliance officer or contact, conducting appropriate training and education, responding appropriately to detected offenses and developing corrective action, developing open lines of communication, and enforcing disciplinary standards through well-publicized guidelines. And if we move over to the bottom of page 80, or toward the top of page 80, another program that targets fraud and abuse is the Medicaid Integrity Program, or MIP. This is a state and federal government initiative to identify fraud and abuse in the Medicaid program. Under this program, Medicaid Integrity Contractors, or MICs, audit Medicaid providers to identify overpayments and to decrease inappropriate Medicaid claims. Okay, so we've talked about our different settings. We've talked about our different caregivers. We've talked about our patients. Let's talk about the documentation that has to happen on the ambulatory side. So documentation involves the process of recording information about the care provided in the ambulatory care center. Among the many factors that influence what must be documented are the type of facility, type of patients, type of caregivers, and internal and external users of information. It is easiest to think about documentation by going through the care process with the patient to see what items of data may be maintained. All right, so let's talk about registration and demographic information. Your first contact in the ambulatory setting is with the registration process. This step is where they gather the demographic information such as the patient's name, address, financial information, and who's the responsible party and insurance coverage. Often this information is first documented by having a patient complete a form upon arrival at the facility. This information is then entered into the patient's record by clerical personnel, either on an information form or in the demographics finance section of an electronic information system or an electronic medical record. Then we have our history and physical. So if you remember from health records, history and physical is documented on all inpatients, but you also receive or get certain information on your outpatients as well. So after you've received the basic information from registration, the actual care process begins. The first step is to find out why the patient is seeking care or the reason for visit and obtaining a history of the illness. The medical assistant or nurse often begins this process by asking the patient for the reason for the visit and a brief history of the reason for visit. Sometimes the patient completes a history form, either manually or on the computer. The comprehensiveness of the history depends on the patient's reason for visit. A visit for a sore throat would require only minimal information, but a visit for shortness of breath would require a more exhaustive inquiry into the patient's past history and family and social history. The healthcare provider, the physician, the nurse practitioner, or the physician assistant then completes the physical exam. Like the history, the physical exam varies in completeness depending on the reason for visit. Then once the history and physical exam begins, the fact-finding process to gain information needed to make a diagnosis and determine a plan of treatment. So this is where our lab and our radiograph reports come in. Simple tests are often provided in the office or clinic, but more complicated procedures may require that a patient be referred elsewhere. Once all the needed information has been collected, a caregiver usually records diagnosis or major problems in a narrative form, and this is where our progress notes come from. In some settings, the documentation for the entire encounter may take the format of a long note, which may be handwritten or typed. In electronic health records, structured progress notes that may or may not utilize templates are common. And then we have our encounter form. At the end of the visit, an encounter form or a super bill is usually generated. This form includes information on the patient's diagnosis and treatments, along with the disease and procedure codes and charges. Usually completed at least in part by the provider, the encounter form may become a part of the patient's record. It may, however, be stored separately because its main purpose is to provide information for billing and insurance processing rather than documenting the care process. So think of your encounter form or your super bill as just part of the financial process. And then you may also have copies of hospital records. So if you're a primary care physician and you work in a clinic and one of your patients has had surgery or they were admitted to the hospital and they have a discharge summary, sometimes those information pieces get entered into the clinic record. And as a health information exchange becomes available in more communities, information can be transmitted electronically between the hospital and the ambulatory setting. And then in the outpatient world, we talked about this in health records, outpatient world, ambulatory world is where you have your problem list. So facilities that see patients on an ongoing basis, a problem list is often used. This is a numbered list of the patient's diagnoses and problems, often including allergies and medications. It should appear in a conspicuous place in the record, usually at the front, and must be updated regularly. All right, so over on pages 86 and 87, you're going to see special requirements for ambulatory surgery centers, birth centers, and pediatric preventative health services. So we're not going to cover those in this lecture, but be sure to read those because there's certain pieces of documentation that are required for those specific areas. All right, we're going to move on over, skipping a few pages, over to page 91 to continue on in our PowerPoint, talking about our record formats. And we did cover these in health records as well, so we're just going to do a brief overview of these. So the organization of data and information is defined as the record format. And there are three common formats for paper records. They're source-oriented, integrated, and problem-oriented. The traditional format is called source-oriented format. And if you remember from health records, it is kind of sectioned off where it's organized according to the source of information. So all of your lab results are together. All of your radiology results are together. All your physician documentation is together. All your nursing documentation is together. So it's put together by the source of the information. This format has the advantage of being familiar to caregivers, but it increases the difficulty of reading the record and integrating data from the different sources. So if you want to know what happened in one day of this day, you've got to go to each tab. You've got to go find the day from the physician's notes. You've got to go find the day from the nurse's notes. You've got to go find lab results for that date. You've got to go find radiology for that date. So everything's kind of separated out. In physician offices, the integrated format is used frequently. In this format, all information is entered in chronological order by visit. Other events, such as telephone calls, are listed chronologically between visits. Test results and copies of hospital records are entered as they are received. This method makes it easy to look at each episode of care, but it is more difficult to look at a patient's care across time, or especially to monitor a specific data element over time. For example, it's often desirable to look for trends in lab values. This is more difficult with the integrated format because the lab results are scattered throughout the record rather than being grouped in one location like we have in our source-oriented format. And then our third is our problem-oriented medical record. This record was developed by Dr. Lawrence Weed to provide a more systematic method of record keeping. The key component of the POMR is the problem list. As discussed previously, this is a list of the patient's problems and diagnosis and serves as a quick overview of the patient's health. Information in an EHR, because we're going to move on now, we have our three paper record formats, and then we also have our electronic health record. So flipping over to 92, starting at the paragraph that says the number of ambulatory care providers utilizing electronic record formats is increasing, at least in part because of the incentives in the ARA HITECH for adopting electronic health record systems, and later the penalties for failing to adopt. Information in an EHR can be organized and entered in a variety of ways. The provider should select a certified EHR system with a format that will facilitate meeting the requirements of meaningful use. For example, some ambulatory providers have previously adopted electronic systems that incorporated clinical lab results into their electronic medical record systems as scanned images, which would not meet the meaningful use requirement to incorporate lab results into the EHR structured data. All right, so the last slide we're going to cover in this lecture is going to be filing. And so we've talked about filing before in health records. The term patient identifier refers to how the patient is identified in a health information system, whether it's paper-based or electronic, and how information about that patient is located. In small settings, the patient's name may be the primary identifier. In a paper-based filing system, or if a paper-based filing system is used in such a setting, the records are filed alphabetically by the patient's name. Such a system quickly becomes cumbersome because patients frequently have the same name. And we've talked about this. It's not convenient. I think we read one time that about 50, and don't quote me on this, but I think 50% of the patient's names fall over 6 letters in the alphabet. So, you've got letters that have just a lot of names. A's, for example, W's, M's, those are common last names. In an electronic system, although the patient's name may be used to access that individual's record, electronic records must utilize a unique identifier for tracking the patient associated with a given patient. The patient's name is not suitable for use as the patient identifier in an EHR because names are not unique. You can have father and son with the same first name, last name. Because typically senior, junior, third, fourth, those are not part of the name. Those are going to be a suffix. And so first name and last name are exactly the same. When a system is too large to use an alphabetical system, a number usually assigned to the patient. And depending on, how they assign that number, there's various methods. If you flip over to 94, one way is to first decide the number of digits to be used in the number and then start at 0 and assign from there. And that's your straight numerical order. And then you can use terminal digit order. We used that in the past. That's more for your filing for sure. And then we have the family numbering system. Family numbering system is over on page 95. With this numbering system, the family is assigned a number. All members of the family use the same number with the suffix specifying their unique identifier within the facility. The family number might be 425687, with the father being 425687-1, and the mother being -2 and the child being -3, with that 6-digit number in front. This system may be used in settings in which the whole family is treated and when social and medical information about the entire family might be helpful in treating individuals. Family numbering can also be used for billing purposes and mailings to family members. With the frequent changes in family structure because of divorce or other family breakups, however, keeping up with the family unit and changing the record system to match is frustrating and not always possible. All right, so we're going to end this lecture here, and we're going to pick up with reimbursement in the next section. Happy reading.